the baseline pain and peripheral symptom information. So he would have asked Gracie what her pain was like in her low back and get a number on that, and then what is it like down in her leg and get a number on that, and then ask how far down it's going. So we're gonna say that it's the right, it's the symptomatic side.
Okay.
So after he's done all that, then he's going to do the unilateral straight leg raise test. So he's gonna come around to the affected side for this, so come on around.
I don't know if I remember.
That's okay. So all he's basically gonna do is passively lift the leg straight in the air with her, but explain to the patient before that I need you to, Gracie, to totally relax. It's not you to lift your leg, so I don't need you to help at all.
Okay.
Okay, so then he's just gonna raise that up to as far as you can go, and as you're lifting the leg, you're asking what?
Is there sharp shooting pain?
Right, do you feel any sharp shooting pain down the leg? And if she does feel sharp shooting pain between what and what?
30 and 70.
30 and 70, then you can bring that down. That's a positive test for two things. I said
Is it the SI? Oh, no, sorry, that's the other one.
Right, that's what-
Lumbar herniated disc and lumbar neural issue.
yes, it's either a lumbar herniated disc or a lumbar neural dysfunction or neural issue there. Okay, so that, but if he raised the leg, so Brayden raised the leg up again, and Gracie's like, I'm not feeling any of that, not feeling any of that, I'm not experiencing it. Then you go to where? The point of limitation of resistance, and then you back off just a little bit, and then force her Brayden into dorsiflexion. Force her into dorsiflexion. Is that causing any sharp shooting, radiating pain down the leg? If they say no, and then what else would I say? Or is it just feeling, Gracie, like a stretch, like I'm really stretching her? So she just says that, and then you do it again. Force her into dorsiflexion again. What about then? Stretch. Okay. And then again. 3 times. Stretch. Okay. And that would still be there if that caused that radiating pain down the leg, sharp shooting pain. That would be positive for those two things.
You said lumbar herniated disc. What was the other one again?
Lumbar neural dysfunction.
Neural
or
dysfunction.
deficit.
Okay.
Something lumbar.
So would that be something like sciatica? Or-
Right, sciatica, bone spur in the lumbar spine. Okay, so that's the unilateral. So the unilateral we said was a passive test, so that allowed for the patient to not have to contract, which was a good advantage of that test, because once you have them bringing in other muscles, you're likely to increase low back pressure, which can lead to a possible false positive. Okay, so then the well straight leg raise.
Gonna do it on the good leg.
Right, go to the other side, so you go to the well side or the uninvolved side, and it's the same procedure. He's just gonna lift her leg, and he'll be asking the same questions as he raises the leg, but this time he's making note of when the symptoms are occurring over here on the involved side. So if you'd ask Gracie what, right,
If she's having any sharp shooting pains.
but make sure you say down the right leg, the involved leg. And then as he goes up, so bring her back down again, Brayden. And as he's going back up, this is where the 70 degrees comes into play. So you have to make note of when the test was positive. So if they were symptomatic before 70 degrees, that was SI, and then after the 70 degrees was the lumbar.
There's not that rule on when you do this side.
No.
Alright, okay.
No, when you do unilateral, that's not testing SI. Okay? So then Brayden will come around again. And the bilateral straight leg raise is still passive and good. He's holding correctly. You want to hold at the knees so they don't bend the knees, and you're just raising that up and asking if they're having that sharp shooting pain and looking, is it before or after 70 degrees, and that's still going to be indicative of either SI or the lumbar issues. Okay, so with these 3 tests, we talked about one thing when you're reading the chart, what are you going to notice if in these about when you see this test done, is it usually done in isolation or not?
It's always, always paired with another.
Yeah, paired with another test. So when you're reading, they're not gonna just do the straight leg raise, because they're basically doing another test. Thank you guys. Actually, Grace, stay up here.
Is the unilateral one the only one where we get
Let's go. Let's go.
Yes, the other two do not. So with the straight leg raise test, when you're reading an evaluation, they will be paired with another test. And really, it's pairing it to do what? It's looking to confirm what you're seeing with this test, and also do what? It's actually providing more information than just this test alone.
Cause that's just saying we have something wrong. But
Right.
We would need to find out what.
Yes, because you notice it's either, it's vague, and it says a herniated disc or what, other lumbar issues.
Anything else.
So you're like, okay, so you're gonna be seeing more tests done to differentiate or identify a more specific problem. The same way with like the well straight leg raise and the bilateral straight leg raise, if it's telling you SI, there are other tests that we're gonna do that are more specific for the SI, that delineates the specific SI problem that is going on.
If there's an issue at the 70-degree mark, like you said, it was going to be an SI problem before the 70
Yeah.
degrees. Okay, is that for all three tests?
Not the unilateral.
Not the unilateral.
The
so
unilateral is not an SI test.
Okay, just the bilateral and the well test. Okay.
Yeah, the bilateral and wells are looking at SI, whereas the unilateral is solely for the lumbar. Okay, so any questions about the straight leg raise test? If not, we'll move on to Eli's test, and this one I don't think is in your book, so make sure that you're watching this one. So the Eli test is a test for femoral nerve impingement. So instead of looking more at up higher at the central level, this one's just looking at the peripheral femoral nerve. So this one is the same starting point. You would still bridge and you would still get baseline pain, and the patient position is prone. So I'm going to say that it's her left is affected. So she's turning, we'll say she's already bridged. Okay. So for femoral nerve impingement test, it's two parts, and this, you kind of already know, all we're really doing is a hip flexor stretch. So I'm taking her into full knee flexion first and asking if she has any radiating pain where. Well, think about the femoral nerve, where the cutaneous, there you go, the cutaneous distribution of the femoral nerves on the anterior thigh. So it would just be there, right? So if you're having any radiating pain or shooting pain down the anterior thigh, if that were the case, that's a positive test for femoral nerve impingement, and you would stop there. But with all of these neural tension tests, it's still very important that what are you differentiating for them? That if it hurts, just like a stretch, that's negative.
Right.
So you always say that to them. Gracie, does it feel like I'm just stretching like you're tight, or is it truly sharp shooting pain?
Like a burning pain in the quads versus like a pulsing pain
Or a sharp shoot, like a shooting,
Yeah.
sharp shooting pain. A muscular pain is more like a burning type. It's just really tight and you're stretching it, like
What
a
if-
tension type of pain instead of a.
What if there's like a muscle strain in the quad? Can that give you like a false positive on that? Would that be sharp shooting for them?
Possibly, if you still don't, because that is more, if it's a quad strain, a lot of times it will feel that way in the belly of the muscle more than radiating, like shooting. It'll
Okay.
kind of all go to where that quad, particular part of the quad that's irritated is. But not to say that there are sometimes, if it is early on and they have a quad strain, you could get a false positive here. Okay, and then you just bring her into full hip extension, holding the flexion. So if she says no here, then you move her up into here. And she should be belted for this, because see what's happening to Grace, there's a lot of rotation, which could result in a false negative. So I'm just asking her those same questions, is that, causing that radiating, sharp shooting pain down her anterior thigh, and that would be positive for femoral nerve impingement. When is this prevalent? When do you see this? What is the cause of these femoral nerve impingements? It is more rare than sciatica, more rare than like lumbar herniated discs, but they are finding that with the new anterior approach, total hip replacements, so the new, I don't know if you got to listen to the lecture, if you have not listened to it, but this is new information that I wouldn't have said on the lecture that you listened to, that they're finding that has been a lot of irritation to the femoral nerve long term, and it can last up to 6 months post anterior hip replacement. And I have had lots of patients that have had the new anterior approach hip replacement surgery that will continue to complain of pain that's all over their thigh, that just won't go away. And they've got figured out that it's coming from where they had to be positioned so long with the femoral nerve on tension. Because that, like I told you, that table that they use, they're positioned like this during the surgery. So think about how much tension they have on that nerve.
So is that with the anterior approach or posterior?
Anterior approach, the new anterior. We love the anterior approach. How would you explain that to them now that I told you the cause of it, and you know 2 things why it goes away? Why would you think it goes away?
Just typically by that point you've fully kind of recovered from the surgery, so there probably wouldn't be a whole lot of inflammation or swelling in the area that could result in the impingement.
Well, but they're hopefully not, but what resulted in the impingement initially?
Too much stretching.
During the surgery,
Right.
so they're not gonna be, it's gonna be less stretched after a couple months than what it would be.
Right, because are they in this position anymore?
No.
So basically, they're not in the position anymore. So the aggravating position has been removed, and they haven't been doing that. And so when they don't do the aggravating position, it's going to start doing what?
Just going back to
Like,
normal.
back to what
Being
was it?
being less compressed and having less tension on it. And if there was, damage to that peripheral nerve from the tension, what do they have the ability to do?
Regenerate really slowly.
Yes, right, really slowly, but more so with these patients, and in that study, they do, when they talk about patient education, they said those are the 2 points you could say, but which one really is it that's allowing it to go away? It's the first one, because true peripheral nerve regeneration takes even longer can take a lot longer than 6 months.
So whenever you stretch out nerve,
Is then going to be long.
so in the sense of like you're out of surgery and you're just resting the nerve itself, does that eventually just elastic kind of go back to normal over
Right,
time?
recoils, yes,
Okay.
yeah, that tension just alleviates, just like, if, because think about when they're in that overextended position, when they're out of surgery, it will start to begin to slowly
Okay.
recoil and get back into that, its normal position.
So they would test positive for this test.
Yes,
Okay.
yeah, they would test positive for this test. But will we be doing this test on them?
Probably not.
Could we do this test on them if they've had the total hip replacement?
Yeah. If it's an anterior, yes, because there are problems with extension and external rotation. That's a precaution.
Well, if-
We're taking them into the extension.
Oh, yeah, we know.
Think about this before you answer. Remember we talked about this during the practice, because some of you, I think, know the answer, but then you're like, I've spoken too fast. Let me ask the question again. do that with the new anterior approach?
Yes.
Yes. Because Jordan, I think you're thinking about the old anterior approach. That makes sense. Because what's so great about the new anterior approach, but if you haven't watched the video, that's totally fine, but they,
I've watched it.
that feels good.
Is-
Stretching your quad.
Is it okay to do it in passive?
There aren't positional restrictions.
Yeah, there are no restrictions.
At all?
It's only
Well,
the pivoting.
Except, very, good, Braden, except,
Yeah, pivoting.
yes, pivoting when you're turning, except torsion, twisting, when you're turning, they still have to take those tiny steps.
In regards to the lecture, when it talks about extension, was that only talking about the old interior approach?
Right, and let's call, and we'll call that old to L3 herniation. And this test, when you're looking at how the results are, do you think they're pretty reliable and pretty valid for this test? Yes, they're reliable and valid. The only real disadvantage is if you don't stabilize, like I talked about, then you're gonna get false negatives. And I will just go ahead and use what Blake said. You can get some false positives with other quad-related injuries if you do this during the acute phase. Okay, Grace, I'm gonna have you just stand up since you're up here. And the next test that we're going to do is on your list is the Slump test. So I'm gonna have Gracie, this one's done in sitting. So Grace, want to sit down. And did anybody tell me that they saw the, Slump test at Marshall when we were doing, cause this could have been done there for the patient that was at Marshall. Okay, so what would we have had done, cause all of these, you started out, and I'm gonna have you scoot over so I can sit beside of you,
This way.
that way.
Okay.
Bridging.
Bridging,
Bridging, yes, bridging,
Asking about the pain
good,
and how far it's radiating down,
Very
and
good.
then the rate of that pain as well.
right, very good, so you would have I would have gotten all that, and we're still gonna say that Gracie is going down into this right leg of hers, and down into the knee, down to the knee. So once you have that information, then you're just gonna have her to slouch down,
I'm already
slouch down.
No change.
And then when she's in this slouch position, you just ask, is that causing that provocative, sharp shooting pain down into this leg? And if they say yes, you would stop the test and call it positive. And I'm gonna tell you what that means in a minute. So then after that, then you just have her to straighten the affected limb out and still stay slouched. So she still stays slouched, and you're asking the same questions. Does that cause that provocative radiating pain? And keep your head up though, it's like this, you're slouched. Make sure they don't do this until you tell them to, so they're just slouched, looking straight ahead. And if that doesn't cause any, provocative symptom, production, then you have them to dorsiflex the foot back and ask if that causes any of that radiating sharp shooting pain. If it does, you quit. We'll say that Gracie says no to that, and then you have her check her chin. See if that causes any radiating pain at that point, and then if not, you can continue on with overpressure. Keep that out. Overpressure to the neck flexion, and then see if that causes any reproduction pain. And then if not, then you overpressure the dorsiflexion and ask. Now, Gracie, tell them what that feels like, because this test is very uncomfortable because it's truly inducing neural tension or a stretch to nerves from the cervical spine all the way to L spine.
This feels like a big stretch.
So everything's kind of attached in there, the fascia, and so all that, you get just a good stretch. So they're gonna feel, that's gonna feel uncomfortable to them. So again, just explain to her, if they do say, oh yeah, right after that just say, and again, does that, Gracie, feel like it's just a kind of stretching, or does that actually feel like it's a sharp shooting pain down the leg? Okay? So for, I'm gonna have you just stay right here. For the slump test, this is testing positive for neural tension. I'm gonna say it this way, the book doesn't say it this way, but just put general spinal neural tension. So it's just general spinal neural tension.
And that's what it's testing for?
And that's what it says. So it's positive, that's what it's for.
We use these as, I think we call it sciatic nerve glides.
Yes, this is a great way to do sciatic nerve.
What's like,
Flossing, you can do sciatic nerve flossing in this position too.
okay.
And I know you're gonna say something else, but I'm gonna say this real quick, because where Braden brought this up, it is good for you to know, any neural tension tests that we're doing, they can be made into a nerve glide and floss technique. So a lot of these positions, you'll see with treatment of some of these neural tension issues.
What's the difference between the glides and like the tensioners? I think there's really kind of two different things.
Yeah, flossing is where you're doing the quick repetitions, like you're kind of trying to floss that nerve, move it within whatever groove it's supposed to be stationed at anatomically. So you're kind of, it's more like a repetitive stretch than static stretches.
So would it be like
Okay.
doing dorsiflexion?
Right,
That-
just having them just back and forth quickly. That's more like a nerve flossing versus a static nerve glide where you're just having them hold that.
And this
Or
that just
hold
kind
it,
of
you know.
helps with pressure on the nerve, like if it was getting like impinged by like muscles and things like that.
Yeah, the way you would do, it's just stretching the nerve,
Stretch it. Okay.
just stretching the
That's a good
nerve.
way to put it.
So it's causing it to, you know, get out of that compressed position or state. That's it. So what do you all think about this test? Do you think it's a good test? Used a lot? Is it not real reliable? Not real?
I feel like it'd be reliable but harder for the patient.
Right, it is harder. One of the biggest disadvantages, think about that, like Gracie said, why can a lot of people just not do this test?
If you're too tight.
Right, if they're too tight anywhere, like if they have very real tight hamstrings, it's hard to do because they are not gonna be able to get full knee extension. So if they can't get the full knee extension, then that, if they have a tight calf and can't get full dorsiflexion, no. If they don't have good cervical flexion, then no. So that's a very big disadvantage of the test. Another big disadvantage is it does not identify spinal level problems. It just tells you there is a problem, but it's not for the cervical, it's not distinctly for the thoracic or lumbar, it's for them all. So that is a disadvantage in that it doesn't really show what part of the spine is being affected. Now, do we know? Probably based on their subjective complaints, somewhat where it might be, but this test doesn't tell us that. Because with Gracie's symptoms, you would think this is probably what part of her spine?
It was going down the leg of the lumbar.
Yeah, just the lumbar, because it's going down her leg, not the arm. So this test, then the advantage of this test is that the positioning can be used for treatment. So it can be used, this position is a great position you can kind of modify it to do a lot of nerve flossing techniques. And it does allow you to do what? Test the whole spine at once. Because you are able to test the cervical, thoracic, and lumbar at once. So when you are reading a chart, if I ask you the question, if you're reading a chart and this test is positive, what other tests could be done and also positive when you look in the chart that you already know?
Straight leg raise ones.
Yes, the straight leg raise.
Eli's test.
Big lies could be positive. What about, the, thoracic outlet ones, could they be
Yeah, 'cause
positive?
we don't know where the stuff
Because we
is.
really don't know, is it more, could it be, thoracic? So again, it's very non-discriminative of which level it is, but, again, it can tell us that something's going on at all 3 levels at once. Okay, so that's the slump test. Manual traction I'm not going to do because you know how to do that one for the lumbar. How would we do that? It's just like we did for cervical manual traction for a test. We would have Gracie do what first? Bridge, and get her right baseline pain. And then we would just do the distraction technique on her with the belt, how we did when we learned the distractions. You would position her in supine and have the belt, and then just pull back, and then I would be asking her the questions of, is the pain getting better, worse, or staying the same in your back? Is it getting better, worse, or staying the same in your leg? And is it changing how far down it's going in the leg?
Are we still doing grades, or are we just pulling and asking?
Well, think, what grade would we do if we're doing the test? We're doing grade
2, 3. Is there a better way to get the thoracic region? Because I feel like I mainly felt it in the lumbar when people were doing that one.
Well, this one's only for the lumbar.
Oh, okay.
Yeah, this is only telling us that there's a lumbar issue.
Would we have to worry with this about like going harder or like putting more force into it compared to cervical? Because I feel like the vertebrae are bigger.
Oh, yeah, this one definitely, a grade 3 is gonna be more intense than a grade 3 in the cervical
Yeah.
spine. And that again is where you all don't really know how to feel that. I mean, that's why during the practice, I was really just asking, what is a grade 1, a grade 2? You all said it, right? You know what it is. A grade 1 means what?
Taking up pressure or taking the pressure off the joints.
Yeah, just
pretty much.
loosening it up, and then a grade 2 is
Taking up muscle slack.
taking up the slack, and what happens to the bones? They
Partial separation.
partially separate, and then, once you get to a grade 3,
Stretch the
you're
muscle and
stretching
full separation. of
and full
joints.
separation. So, but you don't know how to, and especially in the cervical spine, I wouldn't want you to go out on your clinical and just start doing a grade 3 joint distraction on the cervical spine. You know what it is, but you're not really getting to that true 3 yet, till you have experience with your hands and feeling it, all of those things. But, so we do get, to do this test, you've gotta get to a grade 3 for it to be reliable and valid. So once we do that, and then a positive test is what?
Pain going away.
Pain going away. Right, pain is somewhat getting better. So if this test is positive for the pain getting better, then what is it indicating? It's either indicating the same way what we said in the cervical spine. It's either a herniated disc,
Or just a neurological problem?
A nerve impingement.
yeah, the bone spur. Yes, the bone spur. It's either a herniated disc, or because think about why this makes you feel better with a herniated disc. It makes you feel better because you're doing what?
You're separating the discs from each other. Or the vertebrae.
And then what's happening to the disc?
Go backward.
Shifting backwards.
Right, you're relieving pressure off that so it can move back off of that nerve. And then it makes a bone spur and arthritis feel better because what?
It's separating the bone
Apart.
spur from pressing onto the nerve.
Right, yeah, it's just moving that bone spur. And then those patients who have a bone spur and DDD, what's it doing to the cartilage between the vertebrae? It's compressing that, so that makes them hurt too.
Yeah.
So they're gonna be like, my low back feels good, and my leg's starting to feel better too, because it could be helping with that spur, plus just relieving that cartilage pad. It's good taking the pressure off where it's bone on bone. So a positive test is gonna be the relief of their pain, for those 2 things. So both, we said, what was the biggest disadvantages here of lumbar and cervical distraction is with this one, you can't do it if they have any laxity at the lower extremity, like the hips, the knees, the ankle. You couldn't do this test or if they had any of the other contraindications to mobilization. But it is, what's the advantage of these, that like with cervical manual traction as a test, you can also do this as a treatment, so that's an advantage. The test can become treatment and it is very reliable and valid if done properly. Okay, so the next test is the one that I spoke about on Monday. The repeated mobility test I told you to add as 8.5. Remember, I wrote it up on the board, so hopefully you all have it written down already. So the repeated mobility test is the repeated extension and lying and repeated flexion and lying. Yes. And this is the test that we've already talked about. Just stay seated for a minute. That even when we went over McKenzie, this is the McKenzie technique uses this repeated mobility test to identify those biases. Do people prefer to be in a flexed or an extended position based on what their injury is? So these biases can help us understand what type of injury the patient might have that's causing their peripheral symptoms. So before I do the test on Gracie, I did want to, what group did the McKenzie way back in the fall? Jordan, and who else was in there? Okay, so yeah, so I'm gonna have you all think back to that, think back to McKenzie and because they did a great job with their presentation on this back in the fall. So if you remember, what were some things when you think about the McKenzie method that you remember? Told you that. I'm glad I didn't do that.
I remember I focused on the Maitland method.
Oh, okay, so you were not, Jordan, did you do this, or was that Carly who did that? You see, y'all could just say that, cause I could ask her right now. Okay, well, the McKenzie, just maybe this will spark your memory. When you're thinking of the McKenzie method, this is a very universal method that's used to treat low back pain. So you all are gonna see this in definitely if you're in an outpatient setting, but you'll see it even across settings. So you need to be aware of what it is. So the McKenzie method, it includes exercises for the low back, but it also includes identification of problems in the low back. So when you think about the McKenzie method, think about coming up with biases. And there are these terms. This is what I was hoping that Jordan and Tessa may have remembered. These two words are very important when we do, and even when we do this test.
Oh yeah. Oh, direction and dysfunction.
Yes, yeah.
Isn't there a posture too?
Yes, Jordan, you are correct. I'm gonna write it up here because there is postural. The repeated mobility test doesn't really help us understand if there's a postural component to their back pain. But so the repeated mobility test, McKenzie identified these three main problems that contribute to back pain, that contribute to pain, or back and neck pain, postural issues, a derangement, or dysfunction. So the derangement, by definition, is a disc problem, or most likely herniation. So just put out from that H&P, herniated nucleus pulposa. And then dysfunction is muscle and posture. So a dysfunction, I'd like for you to think about more like the patient has a muscle strain, like a muscle strain in the back, or their posture is so poor that what do you think's happened to their muscles? They've gotten really imbalanced, very tight on one side and loose on the other. So that has created, because they have poor posture, they've created issues with the muscle being really tight. So they still, dysfunction, they have a lot of tightness with regard to their muscle tissue. And with a derangement, they have a herniation that could be causing radicular symptoms. So this you need to highlight, star in your brain, and anytime you see this, remember these words. That if a patient has a derangement, they will have more pain during range of motion than at the end range. So think about that. If they have a derangement, they will have more pain during the range of motion than at end range. And it's vice versa for a dysfunction. If they have a dysfunction, they're going to have more pain at the end range than they do during the range of motion. And think about that as why that is, because I just told you the definition of a derangement and a dysfunction. So why would someone that has a dysfunction have more pain once they get to the end range versus getting there or during?
Because dysfunction, you're stretching the muscles and they're probably tight, they're imbalanced, like tight on one side, so I feel like when you get to the end range, you're gonna have more.
Right, exactly. When you take a person that has a dysfunction into extreme ranges, when you get them to the very end, it's gonna hurt more than it did just getting there. Because you're like, and they're going, oh, and I get there to the end, that really causes more, I'm having more pain. Then, when you have a patient that has a herniated disc, when they do these motions, they're going to say, yeah, that's making it worse, and it's going to be felt definitely as they're doing it.
Through like the entire range.
Yes, through the entire range. So that's something in a minute when Gracie, when we go through this, I'm gonna be asking her so that I can start identifying what type of McKenzie diagnosis she is, or what category that they would be put in. So when you read a physical therapy evaluation for back pain and you're looking through what they've got, clinics who do a lot of McKenzie, and there are lots of clinics who really are McKenzie heavy in the treatment of back pain, so you'll see these words a lot, like this patient has a postural dysfunction, or this patient has a derangement, so now you know this is what the expectation, what you might see when they're doing their exercises. Before I do the test, I do want you to make a note that the repeated mobility, and I may have already said this, is one of the tests that PTAs most often will be doing. So the repeated mobility test is one of the special tests, because like I keep telling you, the reason that CAPTI wants you to be able to do special tests, it's not to be doing them on a regular basis, it's to make sure that it helps you understand the diagnosis these tests are associated with better. And I wholeheartedly believe that. I think that is great. I was all in, I'm like, I'm glad we have this, but you aren't going to be doing them. That's why, yes, you need to have your hand placement and all those things correct, but does it have to be perfect for me to say they've got it? Because you didn't see me, because normally I would have been getting up and saying, are you exactly right? I'm not doing that, but I do need to know that your hands are at least in the vicinity. But for this test, you all will be doing this, doing the actual test a lot, because this test is used on a regular basis to confirm the efficiency of the plan of care. Because you're like, a lot of times you will have to do this to say, are they still the bias that they were before? And if not, what happens is the plan of care is changed, flip-flopped, because now if they change bias, are all the exercises you're doing going to be different? Yes. So you're kind of flip-flopping the whole protocol of exercise.
So how often do you test it?
So, you definitely test it at a progress and reevaluation, because that's when you're assuring that the plan of care doesn't need to be altered. But it can really be done anytime, because a lot of times you'll have patients who really are not responding well at all to the bias exercises that were established by the PT at evaluation. So that needs to be changed immediately, because if they walk in and say, I am in so much more pain than I was at the evaluation, what do you do as a PTA? Are you just like, oh, okay, good, let's go on and do the,
Maybe it'll be better this time.
maybe it'll work out, maybe this will be fine. How do you delve into that more to think, okay, what do I do with this statement? And do you automatically say, I always hate this too, do you automatically say, well, let me get the PT? What if the PT's not there? And a lot of them, they're not gonna be there, remember? You're gonna be out by yourself, so.
Supervision.
And are you gonna call them, let me call the PT all the time? So if they just walk in and say, I'm much worse than I was the day before, or the session before, what information are you going to get? You're gonna want to know, first of all, how worse are you? Is the pain, how did you feel after the last session? And the key to any type of pain is, after the session, how long did the increase in your pain last? Because sometimes if it doesn't last, greater than 24 hours, it's okay. Remember, you're gonna be sore because you're doing exercises that you have never done before, so that's just normal soreness. So, but if it's not normal soreness, it means it's still hurting. It's still hurting, and I was here Monday and it's Wednesday. That's bad. That's a checkpoint that you're like, oh, maybe this is not. I need to figure out what we're gonna do here. So, okay, so for this test, you're going to have the bridge, and then you're gonna get this baseline pain. So we're gonna say that Gracie did her bridges, and I've got the baseline pain again in her back and down the right leg. So then you're gonna have her come into a prone position. So she's gonna lay on her stomach in prone, and she's gonna lay here for 5 minutes. And as she's laying here, I'm gonna be asking her about, at the end of the one time during the 5 minutes, you're just going to say to her, Gracie, is your pain getting better, worse, or staying the same in your back? And you just note that. And what about in your leg? Is it getting better, worse, or staying the same? And you would make note of that. Either way, you move, even if it's getting better, worse, or staying the same, you move to the next position. But you make a mental note of, did she get better, worse? So I'm going to say that she told me it's just the same. It feels the same. So then I'm going to move on to the next position, which is prone on elbows. So she's just going to put him up on her elbows and look straight ahead. Make sure that you have your patient always looking straight ahead, so you're in that neutral alignment of the spine during the positioning. So the same thing holds true here. You're just going to have her do this position for 5 minutes and ask her those same questions midway through and then at the end. The reason that if it's midway through and she says that it's already making it worse, do you think we are like, go ahead to the 5 minutes or move on?
Move on.
Right, so we would move on. So make sure you make a note of that. If they say at any time that it's worse down the leg, then we would move on at that time. So
What if it improves?
then you just keep having to go the full 5
Okay.
to make sure that it continues to improve.
Okay.
Okay, so for our purposes of demonstration, I'm going to say that Gracie's like, it's about the same. In the back and the leg, it's about the same. So then I'm going to move on to the prone press-ups. And to do a prone press-up, she flattens her hands, and then she just walks out the elbows and looks up slightly. And then she just bends them down and go all the way, and then press up again. And then back down. And then you want to just make sure that you don't have to belt them at this point, but just make sure they're not getting a lot of elevation at the hips. And so she's going to do 10 of these, and as she's doing them, you're asking, is it getting better, worse, or staying the same? But still have them go to 10, but get an idea of what's it feeling like as she's doing them. And we'll say that she's saying right now that it's getting worse, and it's going down her leg worse. And we would go ahead and stop and make a note of that, but we're still going to move on to the next position, because she just said that it was worse one time. You're going to stop the test only when you get 2 of something. So 2 positions that it was worse in, or 2 positions that she was like it's better in. And this test can be over in this position at that time. Because this is, what position are we in? Flexion or extension? Extension. So we're doing the extension part first. So we still have to do the flexion part. Even if she ended early but didn't get through all the positions, we still have to do the flexion part of this. But she just said right now it's worse. Okay, Gracie, it's worse, but we're gonna move on to the next position. So this one, you would belt her down. I'm not going to belt her. Or you can, if it's a smaller individual, you can then put pressure on your hands and hold the hips down at the affected level. This is at the affected level. So if it was down here at L5, I'm okay here. But if it was up higher, the issue is more up toward L2, L3, I would hold her down up higher. Or the belt would be up higher. So you're getting the movement right at the affected level. Okay, so Gracie, I'm gonna have you do the same thing. Really look up as you come up. So this is called a prone press up with overpressure, because she's got the overpressure of me holding her down and getting more extension right at that level that's affected. But then when she looks up, it also gets more extension happening. Keep on going, and then we're gonna do this to 10, asking if it's getting better, worse, or staying the same. And if she does say that it's worse, we want to know, again, is it getting worse while you're doing it, or once you get up there to the end range of motion? So we would have asked her that when she was just doing the prone press-ups. So if she said, yeah, it's still worse, then we would move on to flexion. So we'll say she said it was worse, and we would move on to flexion. But if she had not said that it was getting worse, then you would finish out with, Gracie, maybe stand up. The last part of the test is a standing lumbar extension. So when you have them do standing, they stand and put your hands like this on your hips, because they're going to hinge over their hands. They're just like this. And make sure when they're doing it, they're actually getting lump instead of doing this. Because a lot of patients do this. And what's that doing? Is that doing lumbar extension?
No.
Hip flexion.
Because what's that getting into? I mean, if they do this, but
Starting to flex your knees.
back here, you've got a lot of knee flexion, and instead of back or lumbar flexion, they're basically just leaning back, not extending. Okay, so then you're going to do that 10 times. So all of them are 10 times. And was that a manipulation?
No.
No. That was just
was
a
crazy.
mobilization. And so I'm asking her the same thing. Is this getting better, worse, or staying the same? And again, if she's saying it's getting worse, is it going worse down your back? Is it worse in your back or down your leg? And when it gets worse into the leg, then that's when you're making note of, do I have that in 2 positions before I can say, you're thinking what? If that was the case, what are we thinking? Because I said it was worse in prone press up and prone press up with overpressure. We're thinking, oh, Gracie must be flexion bias because she didn't like extension. But that has to be confirmed. But you're thinking that with what we are saying. So go ahead and lay on your back, Gracie. Move the flexion now. So that was the extension part. So it can tell you again, start to tell you whether they're, what bias they are, but you have to do, during the test, you always do both flexion and extension, okay? So for the flexion part, they're hook lying. And hook lying is this. Make sure for the lumbar spine, you know this is hook lying. And you should think about, this is flexed, right? This was, remember, for lumbar traction, we had them at a little higher, but this is the flexed position. So when she's laying here for 5 minutes, you're just asking the same questions, better, worse, staying the same in the back and the leg. And after that 5 minutes, then you're just making a note. We'll say she said there was no change. It's no worse, it's no better. Then the next part is gonna be double knee to chest. So to do double knee to chest, you have the patient either here and pulling their knees up toward their chest, or underneath here and pulling their knees up toward their chest. Which way do you get more flexion? Lumbar flexion.
Over top.
Yes, over the top. You're gonna get more, because you can put more pressure this way, and you're really flexing that spine that way. So, you would want to do it this way, but clinical reasoning would tell you, would you always want to do it that way? What type of patients would you not want to be doing this?
I mean, old people for one.
Right, well, and you know, most, because again, we want to try to say, my people, my little patients that would say, just cause you're old doesn't mean, because there are a lot of well elderly people now. They really are the ones, but a lot of the geriatric population, why Jenna, would we not, this would not be good for them.
Respiratory
okay.
issues.
I was thinking. Yeah.
Respiratory, what were you thinking, Jenna? Were you thinking respiratory the same, or, no, but there's another reason.
I'd say like bad knees,
Yes,
osteoporosis.
yeah, bad knees. If they have osteoarthritis in your knees, would you want to do this? Or that's not gonna feel good to them if they have severe OA in the knees. No.
Are you
So
saying in that case you can go towards the quads or the
Then you go,
thighs?
then Gracie would just go right distal thigh.
Oh, okay.
And pull their
Below.
wrist, do
Okay.
it that way. And then back down. And if you do it 10 times. Gracie, do it 10 times. You're gonna have to go work out this week, get your workout. So you're doing that 10 times. The most common mistake that patients do when they do this part of the test is they will come down and then they'll pull it to the chest and then they'll straighten your knees out, go all the way down. Now, and just straighten, now go all the way down, that like down like that. Now come up, bend your knees, bend your knees. And then when you come down.
Straighten out.
There you go. Now do that,
They make you do an hour
do that a
workout?
couple times, do that a couple times. And even do it fast, you can do it. And come all the way down. Do we like that? Is that a,
It's not keeping the flex position.
well, when she comes up, you still, I mean, she's still coming, but yeah, it's not keeping that flex position, yes. And what else does that do to the lower part of your back? If you have a herniated disc,
Probably stresses it a lot.
yes, it puts a lot of pressure on the low back. Studies show, and in your Kaiser and Colby book, that's my favorite book, this position puts the most pressure on the spine when you're completely flat like this. That's why if you ever have people who are like, I just lay flat, sleep like that, they're not gonna have, their back is going to thank them for that later. That is a terrible position to sleep in, to be in. You have to have a little bit of flexion of the spine.
Would we be worried, like, if they start, like rolling at the shoulders, like if they're coming off the pillow?
Right, yeah, that they're gonna, yeah, right, that's not correct, yes, cause they need to be that is correct, the scapulas need to be down on the surface too to be a good form. So go ahead and do it the right way now, Gracie. Is she doing it the right way?
You should get back on the table.
Yes, why is that important? The little things are always important. That's why good PTs and PTAs are very technique oriented.
So you're wanting to take it from neutral into that full flexion.
The full
and back
flexion.
to the neutral.
But then you're wanting to keep them what? Keep them in that flex position, but you want them to go back down to neutral, so they're going through the full range of motion. Let's go ahead and do that. So now that we've done that, we're doing 10. And we're asking, is that pain getting better, worse, or staying the same? And we'll say for purposes in here that she's like, that is staying the same, there's no change. So
This
we can
might be a
move to the
stupid
next.
question, but if they're flexion bias, are we doing flexion exercises or trying to move them away from that?
They prefer flexion. If they're flexion biased, they like flexion.
So like we're working on exercises with that, or are we not trying to do extension at all to help?
Right, initially you're flexion. If they are biased, initially during those maximum and into the early moderate, it's all the bias. Whatever they like is what you're doing. Okay?
If
So-
that were to increase the pain, are we then following up with the whole, okay, is it hurting more while you're doing it or at the end range?
At the end range. Same thing if she had said that's getting worse, it hurts worse, and you'd say, is it hurting worse as you're doing the movement or when you get your knees up to your chest? Does it hurt worse there? And a lot of times they'll say, well, I don't know. So then you just have them do it again and say, now do just one or two of them. Is it hurting while you're doing it or when you get to the end range?
Do you do that same thing when it's feeling better? Or is it just?
No, it's just when it's worse. Okay, Gracie, sit up to the edge. So the next thing that you're going to do is have them sit preferably in a chair, but I'm just going to bring this mat down. And then we're just doing seated full flexion. So she's just leaning down, and you want her to flex her head down so she's getting full flexion coming out. And come straight up, just to neutral. And we're doing 10 of those and asking better, worse, or the same leg, back, and if it is worse, this again as you go down and once you get there. And then lastly, if we're still, when would we have already stopped this?
You get two positive or two changes at all,
Well, yes, either two,
positives or two negatives,
yes. And really, we would call,
worsening or better.
right, worsening or better, like two, it got better in sequence, or it got worse 2 times, and then we would stop. And then lastly, press your stand up, feet shoulder width apart. And then do that same thing, just standing flexion in standing. Repeated flexion in standing. So it's RFIS, but standing. RFIS, then you'd have to write out the word sitting so you knew which one. The good news is there are computer, everything's on the computer, so they actually have, most of the eDoc systems have this intertwined in it, all of these maneuvers. Okay, and then we're just doing that 10 times and asking questions. Okay, you can sit down there. So let's talk about what this is telling us. Gracie, you can get back, I'll bring somebody else in, you can get back to your seat. Thank you for. So how do we then know if this test is actually, because remember, it's called the repeated mobility test. In a chart, is it going to say repeated mobility test, positive or negative? It will. It'll say positive or negative. So what do you think would make a repeated mobility test positive?
If you get more than two positive or worsening or bettering of a certain condition.
Right, yes. So that's positive for that. If you get two of something going on. So that would make it a positive test, and it's going to, what do you think, what other information when you're reading it for the patient coming in, what else do you need to know? That it's positive, but for what? Good, Maddie. So how would they write that? It would be repeated mobility test positive, and then they would just say flexion, what? Bias, or extension bias.
Do you have to list what exercises or like what tests you did individually in that overall test?
That, you won't see that written.
Okay.
And you wouldn't, if you're redoing it, you wouldn't write that. That's not written. But when you're reading the chart, how would you a lot of times you can have an understanding of how that went because you can match it up to what exercises then had been picked. Like the PT will normally look at where did they stop at, and then when they put the exercises down, they'll have them kind of match up at that. So again, so we can have, that's nice, isn't it? If it's positive and it says extension bias, then that could let you know what could be wrong with the patient. What's probably wrong with the patient. If they're extension bias, they probably have a derangement, right? If they are anything else that could be going on, according to McKenzie, that's the number one definitive. If they are extension bias, they have a herniation that is posterior. Okay, so if they are flexion bias, though, they have a bunch of things that it could be. So it's not as definitive if they're flexion bias, but you can list laundry lists of exercises that go with that, right? Or laundry lists of diagnoses where they feel good in flexion. And what are those?
Spinal
Like
stenosis.
Right, spinal stenosis, DDD, joint hypomobility,
Facets.
locked facets,
Anterior.
good, anterior disc
herniation,
bulge, yes, good, all of that, all of the things, yeah. So that would be nice. There are other results of this test that aren't so easy and it takes more creativity, is if they are positive without a bias.
If they have one in each position, like they tested that it was worsening or getting better in the flex position, and then also had one in the.
Yeah.
Okay.
Yes, so basically it means that there were two things going on in both positions, and more than likely when that happens, what is it saying?
Dysfunction. Maybe.
Is
Like
it like
muscle
a
tightness?
muscular issue?
Well, it could be dysfunction, you should have listed dysfunction under what bias?
Flexion.
Flexion. Cause why do they feel good when they flex?
They get
You are doing what to the muscle?
a stretch.
Stretching it, yeah. And when you are doing extension, you're constricting it, and it's painful to them.
Would that be different if they like strain something? Like it feels worse as you stretch it? Like they strain the muscle, like
Well, if it's a severe strain, then, and they're acutely inflamed, this test is non-reliable for those. These are more of like a chronic type muscle tightness
okay.
due to a strain. It's more a chronic strain. So let's go back to the thought of if it's positive but no bias is identified.
Could it be a sign of like osteoporosis or something maybe? Or like degeneration of cartilage?
It could be, because what's that mean when it says it's positive but no bias was identified? If there was no bias, it's like, I don't like anything, right? The patient doesn't like anything.
Or anything helps.
Right. Yes, it means that what happened when we did extension, what happened?
It worsened or got better.
Well,
Well,
It got
but if they,
Two.
it got worse,
Yeah.
if they don't have a bias, if they're like, I don't like either of them. Two positions made it worse when you in extension, then when you flipped them over to flexion, you're thinking what? You're like,
This should
This will be
improve.
good.
this is
Should
gonna
be
be
better.
good, this is gonna be better, and they're like, no, that hurts me too. So then, you have a positive test with no bias identified. And those are the ones that are fun to work with. Why is that? Because you're like, what in the world is going on
Yeah.
here? So let me delve in a little bit more. So then what do you think you're gonna do? Cause you're like, well, okay, I'm gonna report to the PT, nothing helped, so now what?
Could it just be like a peripheral nerve injury maybe? Like sciatic or something like that, I would say?
I mean, it could be, what it most likely is they have two problems going on. They have a herniated disc and arthritis. And does that happen a lot? It does, it does. It happens a lot. So when you have these patients who have a herniated disc and arthritis, that's what's going to happen. This test will be positive, no bias identified, because everything made it worse. So the key then is to figure out which is the lesser of the evils, which is the lesser one, the lesser problem. And that only will show its face to you once they start doing the exercises. So what will their exercises look like? They won't be nice, and when you look at the exercises that I gave you, it's like, oh, there's a lot of extension exercises for a herniated disc, and then she has all kinds of flexion exercises for stenosis. But for these patients, you'd have to intermingle the two. So you'd have to have some flexion and some extension, and the flexion and extension exercises you do, you would keep them out of the extreme ranges of that. The best example for that is if you are trying to do extension but not do it real intensely. Because is this an intense extension exercise when I do a prone press up?
Yeah.
Yeah, that is. But if you do a bridge, you have them supine and they extend up that way. That's extension too, but not as intense as having them actually do repeated extension. The same holds true. I have my patients do, like they'll be on a counter and just do hip extension like this. So they're here in more of a neutral type spine, but then I have them do hip extension to get a little bit of spinal extension without doing this, without doing prone press-ups that were intense exercises into flexion. So how would we do with the extension or flexion exercises? How can you do those more gently than having them do double knee to chest? You can just have them do single knee to chest and not do double knee to chest because you have the disc. And the other patient that did the bridges instead of the prone press-ups, we're doing this because of your arthritis. So those are the more complex patients and the more challenging ones, but this test, repeated mobility, is so good at identifying that. So what do we have it's telling you? It's either telling you a distinctive diagnosis, right? If they like flexion, they have this, or this probably. If they like extension, they have the disc problem. And then what was the one I just said? It tells you that they have multiple problems. And then the third is what you already know that I've said, and I know Adele has said it a lot, is when nothing changes the pain, they unfortunately have what?